bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities.
All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And for today's webinar, we would also like to thank Prolacta Bioscience for supporting our webinar program. Prolacta is a life sciences company dedicated to improving quality of life by advancing the science of human milk and providing specialty formulations for the needs of premature infants in the NICU. And we hope you'll join Prolacta at the CAFC annual conference in Quebec City on October 18th. Prolacta has sponsored a lunch session where we will hear from Professor Alan Lucas from the Child Nutrition Research Centre at the Institute of Child Health in London in the UK. As a leading expert in early nutrition and its effects on health and development, Professor Alan Lucas will present a novel approach to devising a 100% human milk diet for preterm infants. So that's going to be a great session at the conference. We hope to see everyone there. And for more information on that session or any other conference information, you can go to www.conference.cafc.org. Right, today's webinar is titled The Tempering Challenges in Pediatric Interfacility Critical Care Transport with Innovation. So it's my pleasure to introduce today's panel. This session again is coming to us from our Interfacility Transport Steering Committee, I guess we call them, a working group, who's done a lot of work in sort of bringing together colleagues from across the interfacility transport community, including one of our presenters today, Dr. Tanya Holt. And they've done a lot of work on developing guidelines and standards and recommendations, and doing a lot of work now with Accreditation Canada in creating standards for interfacility transport of the neonatal and pediatric population. So a lot of great work there, and it's really identified a lot of expertise across the country and a lot of innovative programs like we're going to hear about today. So without any further ado, it's my pleasure to introduce today's panel. First, we'll hear from Dr. Tanya Holt, who is a pediatric critical care specialist and the division head of the PICU at the Royal University Hospital in Saskatoon, Saskatchewan. She's also the provincial medical director of Saskatchewan's Pediatric Interfacility Transport Service. And joining Dr. Holt is Rachel Johnson, who is a nurse practitioner working in Pelican Arrows, Saskatchewan, which is a remote community in north of Saskatoon. Rachel has a lot of experience providing health care in remote areas, including South Africa for 3 years in a remote HIV treatment center in a rural village. She's originally from Toronto, but has embraced the remote communities and is now working in northern Saskatchewan in this really innovative program. So it's going to be an excellent session, and it's my pleasure to hand the virtual podium over to Dr. Tanya Holt. Over to you.
Thank you very much, Doug, and welcome to all the listeners. Thanks for the opportunity to present to you today regarding pediatric interfacility transport and how we're tempering the challenges that I'm sure all the provinces have with pediatric interfacility transport, and we're using some innovation to do this. So my working objectives today are to help differentiate the paradigm of pediatric transport and why redefining our goals is paramount, identify the challenges inherent in providing a comprehensive pediatric transport service, identify an academic partnership that we're using to evaluate the utilization of a mobile remote presence device as a way to temper these challenges, and to identify a pediatric delivery model that really promotes quality and safety and prioritizes healthcare access. So I have no disclosures, and there's been written consent for the patient photo and videos that you see in this presentation. So I'd like to start by introducing you to two patients who have something in common. Both need access to pediatric acute, possibly critical care, and both live in Pelican Arrows, 576 kilometers from Saskatoon and tertiary care, and they're presenting to this clinic where Rachel works. So pediatric transport medicine has grown into a specialized discipline since its inception 20 years ago. Advancements in technology and therapeutic interventions really now afford an opportunity to extend the intensive care environment into the peripheral setting and into the transport environment. Our PICU ventilators are duplicated as our transport ventilators, ventilating as small as 2.5 kilos. We can do blood gases and blood work with micromils of blood. We can closely monitor cardiorespiratory evolution and intervene in real time with multiple infusions. We can even measure continuous cerebral oxygen extraction in certain patients, knowing the effects of altitude on cerebral oxygenation. But despite these advancements, the misapplication of the concept of the golden hour has led to a focus on the speed of transfer to tertiary care facilities, often delaying early goal-directed therapy. The concept of the golden hour really originated from an article published in 1973, which reported a successful trauma service and stated the importance of returning to tertiary care within 60 minutes. This concept has actually led to fewer interventions being done in the field in order to facilitate rapid patient transfer, or the so-called scoop and run philosophy. It has led to delaying goal-directed therapies until the arrival to tertiary care, emerge, or ICU. Despite significant advances in technology and delivery of care, the scoop and run mentality or dogma remains prevalent in our transport systems. Fortunately, pediatric transport medicine began questioning this philosophy many years ago because pediatric patients evolve quickly and must be closely monitored for timely intervention. We are compelled then to rethink the golden hour of transport and ask the question, is it time to tertiary care or is it time to delivery of care? So we all have heard of Rivers, who coined the term early goal-directed therapy in this seminal Sentinel New England Journal of Medicine article. He showed that by targeting tissue oxygenation as reflected by examination endpoints such as heart rate, blood pressure, cap refill, to resuscitate septic shock patient, there was a significant drop in 28-day and 60-day hospital mortality. He demonstrated that by having goals or clinical endpoints that mark the reversal of a pathologic process, you improve outcome. This was replicated in our pediatric population by Dr. Carcillo and is contributing to our algorithm today that we use in PALS. Dr. Carcillo illustrated this concept in a study published in Pediatrics, where he looked at 91 infants who presented in septic shock. He demonstrated that if shock was reversed within 75 minutes, it is associated with a 96% chance of survival and a 9-fold increase in odds ratio. But the corollary to that is that with each additional hour without reversal of shock, there was an associated 2-fold increase in mortality. So if we think of our Canadian geography, and I think a lot about Saskatchewan geography with transport, our pediatric patients actually cannot afford to be scooped up and transported without initiation of therapy in our peripheral settings, real-time monitoring along the way, assessment and intervention during. Another example is pediatric traumatic brain injury, where the primary brain injury is non-negotiable. But close monitoring and early initiation of goal-directed therapies to establish clinical endpoints may prevent secondary brain injury. An example of a clinical endpoint is cerebral perfusion pressure, which is why hypotension is one of the most important contributors to secondary brain injury in children. Hypoxemia and seizure activity also contributes and requires close monitoring and early initiation of therapy to prevent secondary brain injury. Appreciating these risks and monitoring for clinical endpoints can protect the injured brain and is really our responsibility. Sorry. But has there been any literature in the pediatric transport world that establishes this concept that real-time monitoring of clinical endpoints and early initiation of therapy improves outcome? This study is, in fact, the first randomized controlled trial completed in pediatric transport literature, the IMPACT trial. They hypothesized that frequent blood pressure monitoring, near real-time blood pressure monitoring during pediatric interfacility transport would lead to enhanced interventions during transport and associated improved outcomes and reduce the overall length of stay in tertiary care. They recruited 98 patients who met criteria for SIRS or moderate to severe head trauma. The intervention group that was monitored in real time received more fluids and more interventions, more vasopressor support, and overall had a decreased length of stay and decrease in multiple organ dysfunction syndrome. But how do we operationalize this practice and philosophy in the transport setting? We use specialized teams that are familiar with assessing pediatric critically ill or acute patients and can mobilize all levels of care when there are abrupt and unexpected clinical changes. The most common structure is a pediatric critical care nurse, RT, or nurse and nurse, and a pediatric intensivist as medical control. This was a single center prospective cohort of 1,085 patients transferred for retrieval by the Children's Hospital of Pittsburgh. Their outcome measures were unplanned events and 28-day mortality. They compared using specialized teams versus non-specialized teams to see the outcome. And what they found is that, of course, the unplanned events that occurred, the most common unplanned events were airway events, cardiopulmonary arrest, equipment failure and deterioration of the patient, hypotension, and loss of crucial intravenous access. Those are the scary ones, and the ones where you having the specialized team present in real time can change the overall outcome for the patient. So did this translate into an a difference in outcome for patients between the non-specialized and specialized team? It did indeed, and there was a striking increase in unplanned events in the non-specialized team with an odds ratio of a dramatic 245 times more likely to have an unplanned event. All of those very difficult situations you're in en route. It also translated into a difference in mortality where the non-specialized team had 2.4 times odds ratio compared to the specialized team. So we are then obliged to start redefining the golden hour in pediatric transport, because with each hour that passes between the time of illness or injury and the time of initiation of early therapies, organ systems are affected, lengths of stay are longer, and the outcome can be worse. The priority is not the quickest way back to our destination of choice, but rather real-time patient monitoring and assessment for recognition of clinical changes, followed by initiation of therapies throughout the patient's clinical path, from the community hospital and onward. So with that ideal said, there has to be some challenges for this, and there are. We live in a geographically vast country. Saskatchewan, for example, has 1.1 million people, half of which live in 2 larger centers. And the majority are living in outside of those, so the other half is living outside of them, but the majority of our kids are living in remote and rural communities. This is not different in Ontario, British Columbia, and throughout Canada. We have challenges with regard to access, and we heard a previous webinar regarding this. In Saskatchewan, a high percentage of people live in remote and rural communities. This is a chart that's adapted from the 2011 Statistics Canada website. which looks at population centers. And the green bar is what's known as a population center, a place where greater than 1,000 people live. The yellow bar is less than 1,000 people. And what's striking is that in our most vulnerable population for pediatric critical care illness and acute illness, 0 to 4 years of age, 36% of our children in Saskatchewan are living in remote communities, or less than 1,000. Access, therefore, becomes a major issue. So we have geography and access as an issue, but the other issue is that many of our provinces may not even have, and we know this from the work we're doing with the collaboration, are still working towards getting pediatric specialized teams. And provinces like ourselves only have one team. So last year we did 462 pediatric transport services extending from the north to the south, and with one team. This becomes very difficult to not only get to patients in a timely fashion, but to triage patients appropriately, especially when you can't view them. That's a little foreshadow. So we go by fixed wing, and we go some by road as well. And we have, our team is a RT, pediatric critical care RT, pediatric critical care nurse, and the intensivist as medical control. And not to forget the local medical team that we're in close communication with, that we actually in Saskatchewan have educated the importance of initiation of therapy. So we've gotten to know a lot of these communities very, very well, and the local clinicians working there that are equipped with the knowledge and skills to initiate therapy. So human resources is the other challenge. Luckily, CAFC has made this a pediatric priority, and actually since 2008. I became involved in 2012 when we all met in Toronto to start to look at transport system competencies and interfacility critical care, transport of maternal, neonatal, and pediatric patients. This was the start of recommendations for a minimum set of standards for each province, looking at anything from provincial coordination, equipment and modes, transport team models, and how we're going to assess quality improvement, outreach education, and families in the transport setting. This has continued along a very positive path and is now in the hands of Canada Accreditation to make these standards official. This will create an avenue for provinces still without specialized PEDS teams or without enough access to the team based on the volume, to develop funding models with their ministries and maintain accountability to pediatric patients with regards to safe mobilizations. The other important thing for our transport team to maintain these ideals is really to be watching your quality control and auditing your trips. Dr. Anna Gund is working out of London, and she's really done a lot of work in Canada looking at quality metrics and and defining what an unplanned event is, and is in the process of getting everyone together to create a pediatric transport registry, which will really help to hold us accountable for quality metrics. There was this study published looking at quality metrics in neonatal and pediatric critical transport, and it's really what we've been, we established our audit several years ago on, and really looking at Donna Bedian's quality approach for the structure, process, and outcome of your transport team. Anything from the effectiveness of your team and your medical equipment. Do you have access to enough medical equipment? Medical equipment could even be, do we have enough planes in the province to maneuver adult and pediatric transport in a timely fashion? Process can be safety issues. Are you meeting all the safety needs for your team? When you have an intubated patient, are you monitoring end-tidal CO2? All the different maneuvers that keep your patient safe along the way. An outcome, of course, we need to be held accountable for. Our outcome is did your traumatic brain injury patient see hypotension along the transport? Was there any unplanned events? And evaluating them with an appropriate quality assessment after, or M&M. We've just developed a provincial pediatric transport M&M so that we can hold ourselves accountable at all times for this place in pediatric care. So I presented many of the challenges alongside a philosophy that we want to maintain. But because of the volumes, in our province anyway, and I'm sure most provinces, and what I've heard from our colleagues across the country, are struggling as well with refining how to triage these transports. Because of the volumes, there is still a need to refine our approach to triaging pediatric patients for critical care trips, to redistribute them and use our province as well, and our vast provinces, alongside really supporting peripheral centers to carry out the necessary early goal-directed therapies that protect organ systems and improve outcomes. So the goal is to move specialized teams to the referral centers, and at no time will the patient be without opportunity for real-time assessment monitoring for disease evolution and responding in a timely manner with critical care therapies. So how do we really do this? And it is very ideal, and we do have to be flexible, but we have to work towards optimizing it in any way we can. So this led to an important meeting with the goal of utilizing innovation to temper some of these challenges, maintain our ideals and our philosophy, and provide the children of our province and hopefully the rest of Canada eventually with the safe care and clinical goals that are crucial. So Dr. Mendez, who is the department head of surgery here in Saskatchewan, has pioneered the utilization of mobile remote presence devices for point-of-care delivery, healthcare delivery in Canada and internationally, really, with the hopes it will improve access to medical expertise in both developed and developing countries. Dr. Mendez has published this paper reviewing the benefits and opportunities for mobile remote presence devices in healthcare delivery. Certainly, universal and timely access to medical care is a substantial challenge. And remote locations are vulnerable because a lack of access to healthcare really results in poor healthcare outcomes for their populations. Mobile remote presence devices do have the potential to refine our current processes for transport triaging and for redistributing patients throughout our province directly and supporting referral centers directly who are awaiting transport teams. It may allow us to standardize care initiation and develop pediatric expertise throughout the province so we can safely build capacity in our referral centers. So this led us down another path to an academic collaboration. We're looking at using, and we're currently still in the data collection phase, using a mobile remote presence device to optimize pediatric interfacility transportation. This is a feasibility trial. So our study protocol is, our population is 0 to 17 years, acute and critically ill patients presenting to Pelican Arrows Clinic, and we're still awaiting Regina's joining. The intervention is utilization of a mobile remote presence device to triage patients for pediatric interfacility transport and to provide direct support to the local team for critical care management. Our comparison is the cases, which are the patients triaged and managed with the robot, compared to matched controls that are without the robot in communities very similar to Pelican and eventually to Regina for our other group. Our primary outcome is evaluation of the total number of transports performed in each group. And our secondary outcome is length of stay. Length of stay in tertiary care, with the idea that does involving the intensivist directly, who is viewing the patient directly and supporting the local team, does it allow definitive diagnosis and management early, and does that translate into a shorter length of stay? The secondary objective is, are we more likely to utilize a regional center and not bring every patient we transport back to tertiary care because we can view the patient, how they've stabilized directly. This actually has the opportunity to unload the tertiary care centers and more properly redistribute patients based on their level of care and need. So the evaluation of total number of transports performed is interesting because when we get a call for a pediatric transport, we give initial advice over the phone, or we used to give initial advice over the phone, and we base our advice on an evaluation by the local team, and then we mobilize our transport team. The interesting part is we know from the literature as well that there is a certain amount of diagnostic discordance between the patient when you hear about them initially and when the team arrives. And a lot of this could be the initial therapy that they've started has really stabilized the patient, and sometimes to the point that the patient actually does not require transport anymore. This is not the way we want to be using our pediatric specialized transport teams. We want to refine the way we're using it so we are not taking unnecessary trips and triaging our trips to the patients that are really needing them. It really does require refining the way we triage. So, how does it work? See if this works for us. You go to see the patient where he is, and it's available 24/7. It does not require any IT setup or support. Oops. Let's see if this will work. Oh. I'm not sure my video is going to work, which is too bad. Let's see here. Is it working on your end?
It's not. It's just we're just seeing the slide.
Oh, on my practice run, it worked. So that's too bad. Okay, well, I'll just show you then. So this is the device, and it moves to your patient. I had the video working yesterday, but unfortunately, it's not working today. And you have local and remote controls. So the screen that you're seeing under the local and remote controls is what I'm seeing. And I can record, I can take pictures. There are ports, peripheral diagnostic ports that you can attach diagnostics like stethoscopes, ultrasound machines. So in this this picture, I'm actually viewing this young patient here and listening to his chest while I'm watching him directly and assessing him. This is the day after he presented to Rachel on when he presented with respiratory distress. So there's high-resolution cameras for close examination, and this is very unfortunate that my videos aren't working. But this is how close you can get up to see patients, and this is actually Rachel examining a patient's cap refill. And really, cap refill is a nice thing for us to assess whether it's a good exam piece for us to assess when we're triaging acute and critically ill patients, because it enables us to visualize reversal of shock, perfusion, and it's a great thing to decide on whether a patient's stabilized or not. Can we move them? Do they have to come? How is their hydration status? So you can actually see cap refill so well. It's a beautiful thing. I'm sorry that it's not working. So I want to go back to the two patients that had something in common. I wonder if there's any benefit in me trying to pull up my other talk so that the viewers can see these patients' videos. Well, I'll move on, and then I can always show them after if I pull it up separately. So these two patients that I introduced at the beginning of the webinar, patient A was a patient that presented previously healthy 2-year-old girl who presented with a barky cough, severe respiratory distress, tracheal tug, and decreased level of consciousness. But she had a known history of a viral illness, a brother who had a recent viral illness, and she was previously healthy. So she had croup, which is a very predictable pediatric problem for our peds emerge, and we know that we can manage it. This would be a very common patient to present to us, or that we would get a phone call about with severe vital signs, and we would dispatch the team. In the meantime, we give advice to the local team, and by the time our team would arrive, they were much more stable. So this is patient A. Patient B is a patient well known to our system, X27 weaker, very vulnerable chronic chest, who deteriorates fast and is presenting with severe vital signs. So let's move on. So this is patient A's initial presentation. She's 2.5 years old. Heart rate was 153. She was getting I was viewing her directly with the local team and I listening together to her chest. She was receiving an epinephrine neb. And this was the first patient, and it was Rachel who's on the line, that because it's such a predictable pediatric problem, and they do present looking very severe, but it was the first patient where we said, you know, I can see her directly. She has a very predictable history. I want to give her this epinephrine and some dexamethasone. And how comfortable would you guys be leaving her on a monitor and me following up directly with the remote device to assess her, to see if her status has stabilized, because these patients turn around fast. There was some anxiety on the clinic's end as far as keeping a patient for that period and could they manage that. But Rachel rose to the occasion, and the mom and the little girl waited in the clinic. And our plan was that if she needed any more epinephrine, then we would then we would plan to send the team. But if she remained stable after our first assessment and epinephrine, gave her the dexamethasone, we would reassess her in 3 hours. So that's patient A. Patient B, very distressed, and actually the video, I'm so disappointed that the videos aren't working, but the video shows him head bobbing, heart rate of 215, requiring oxygen, initial presentation stats in the 80s, and a known history of him being vulnerable. You can see Rachel here with her headphones. We're listening together, and we're making some very initial management plans quickly. So we initiated stabilization together of goal-directed therapies. We hadn't decided on disposition yet. I knew that it would be either regional or tertiary care, depending on how our initial therapies worked and looking at him directly. So I dispatched the team. So the team started moving to them while we managed the patient directly. So in the video, what you see is on the left is he actually stabilized very nicely. And on the right, you see me discussing with the local team, Rachel and Jim, and the parents and the patient directly regarding what would be the best disposition for the patient. Prince Albert is a regional hospital with a wonderful general pediatric program, and the family actually has support systems in Prince Albert. So at that time, we discussed that with the initial therapies, we had decided that he was likely stable enough to be moved to Prince Albert. So a great opportunity to have an open conversation with the family and the local team about triaging. So this is our patient A. A few hours later, when I reassessed, and Rachel and the mom was delighted. We had the opportunity together, Rachel and I, to give recommendations of when to follow up in the night if she should worsen, and the mom seemed very happy with that. And And that is a patient that we would have moved to Saskatoon or maybe PA with that initial phone call. But because we could see her directly, we were comfortable initiating therapy and waiting a bit for reassessment. She was lucky enough to sleep in her own bed that night and didn't need to return to the clinic. Patient B did come to hospital, spent a couple of weeks convalescing for his viral respiratory infection, but never did need critical care, so was triaged appropriately and directly from the initial triage, and he did very well. So what are our preliminary results? We're still in the process of collecting data, and we don't have our length of stay results to present today yet, but we will follow up with those. But our results are actually quite striking, but not surprising. I'm sure throughout Canada, everyone's thinking the same. There are those transports that you go on and you think, oh, we didn't need to go for that child, or oh, we should have went for that child. Or so interestingly, we've done 35 trips, and if we in our matched controls in our transport database, which we've kept for many years, we looked at matched controls, and when we receive the call for an acute or critically ill patient, we go and pick that patient up. Very rarely will the team say, oh, this patient is quite good and won't need critical care. They can move to a regional hospital. But we do go pick them all up. With the cases, meaning assessing with the remote technology, the RP7I, we've actually reduced our number of transports, and we only ended up going on 40% of the transports that when we were called for those acute patients. We were able to manage many of those patients with the local team and with reliable follow-up and direct assessment. This was striking and made us all realize that really we do need to refine the way we're utilizing our specialized teams, and we can actually manage some of these acute presentations in the local community with a great local team as we build trust with them because we can see each other directly. As far as regionalization, 42% of those 14 that we ended up having to transport, we said we could see them directly and we were comfortable saying, no, we can send you to PA. You're not going to, you will likely not need critical care in the next 24 to 48 hours anyway. And that is a change from the way we were triaging patients over the phone, where we were only 8.6% of our patients would we regionalize if we were doing it indirectly. So already really kind of showing us that this helps refine the way we transport, and it also has some other benefits that were really unexpected until we started getting into the study. One of them has really been the satisfaction that it's created, and I'll leave a lot of this for Rachel to speak about, but the satisfaction at our end to be directly involved with some of these this extraordinary local team, and how they have just risen to the occasion of learning about pediatric acute care resuscitation, having the confidence to do it, and how this has allowed them to hone their pediatric skills, to actually manage patients in the community and keep families in the community. So there's been a significant amount of family satisfaction too, which when you discuss robotics or remote technology with anyone, the first response you really get is, well, how do you bond with a robot? And it's really not about that. It's about access and moving access that won't normally be there, or moving specialized care that won't normally be there to the patient, and really having a direct means to work with a local team. And I had a medical student working with me on a Dean's project this summer for this study, and he saw a few patients with me, and all of the patients that we're triaging or that we're recruiting for this study, we do have to follow up with them to make sure that we're not leaving patients in Pelican and then 12 hours later they're getting sent in an ambulance at 2 in the morning. So we do have Rachel following up with these patients and ensuring that they're doing well. And one of the patients we followed up with one day actually gave the robot a bit of a hug, which was just our little picture to show that who says you can't bond with a robot, right? In any case, there has been a mentoring, a real growing relationship that's directly a real mutual respect that we've developed, and it's been extraordinarily satisfying on our end. So the final thing, of course, everyone wants to discuss when you look at cost effectiveness is it is better for the it's positive for families if you can leave some of these unnecessary transports within their community because they stay with their family. But there is a cost effectiveness which is good for governments and ministries and all the people that we need to discuss costs with. And in our province, to travel north, it's approximately $10,000 a transport. And since we started this study, you can see we've saved a lot and in a safe way, and it's developed over time. We're still looking at mean hospital length of stay, and does actually being involved directly with those patients that ultimately end up in tertiary care, is their length of stay shortened? We're still analyzing that data. And certainly by regionalizing patients and keeping them closer to home for their level of care has a hospital savings. The other thing that is important to note is that definitive diagnosis, early initiation of therapy can translate into a stabilized patient that stabilizes and may need less high acuity in your hospital, which may translate into lower dollars. So, with that said, pediatric intrafacility transport is really changing in our province and in our country. And there is lots of opportunity to optimize things. We say that the road ahead in Saskatchewan is promising for acute and critically ill children outside of tertiary care because despite the challenges and increases in volumes, we hope to temper this with innovation using this mobile remote presence device and develop a programs throughout the province in our remote communities. This may enable us to remain steadfast in our philosophy of early initiation of therapy in community hospitals, and then evaluate the patient while awaiting the patients that need to be moved while awaiting safe pediatric interfacility transport, and may allow us to create a redistribution model in our provinces where children receive the appropriate level of care closest to home. So our Canadian geographical range presents challenges, but changing our clinical standards to incorporate remote presence devices is a potentially transformative method for addressing a deep and ongoing gap in healthcare access. I'd like to thank particularly Pelican Arrows Clinic and Rachel Johnson for their openness to this opportunity and feasibility trial to see if we can move specialized care to PEDS patients in their community and refine the way we're triaging these children in and out of their community. They've been incredible. Dr. Mendez for his vision, and Dr. Jibelishin, who's the head of our department, and Dr. Rosenberg, our head of our research department. And so the pediatric transport team and so many other people involved. Those are my references, which you'll have. And at this point, I'd like to I guess I'll hand it back over to Doug prior to him introducing Rachel Johnson, who actually took this photo from her balcony where she lives in Pelican Arrows. And it's been a great pleasure to work with her. And she's quite an extraordinary role model and champion for this initiative. Thank you very much. And my apologies that my videos didn't work. How disappointing.
Yeah, that is too bad that those videos didn't work. It really brought sort of the whole thing to life to really actually see it in motion. So maybe we can get some of those available on the Knowledge Exchange Network afterwards if if you can give me access to those videos, perhaps we can put some of them up there. We did have a couple of questions before we move on to Rachel. We'll let her get a chance to get set up. But the first question that came in, and actually a couple people asked this question, can you tell us the cost of the robot?
Yes.
You talked about the cost savings associated with it, but what's the initial cost of the robot?
It's a really good question. I only did the one side. So there's several different types. There's the first robot that you saw on my cover page is called a doctor in a box, and it is actually very affordable. It's between $35,000 and $40,000. That one isn't mobile. The clinician that's working in the local community has to move it around. It literally is like a briefcase, a doctor in a box. But the mobile one that we have in Pelican Arrows is between $80,000 and $100,000. So you can see that it doesn't take long for you to save the amount of money that you'd pay for a robot.
Yeah. And Penny was asking, what technology is required to use the robot remotely? Does it require more than just regular telephone lines via satellite? Do you need high-speed internet of a specific level?
So you need Wi-Fi. You need your laptop, and you can use internet if you want, but you just need your Wi-Fi really. And actually, I'll tell you a funny story. You can even use 3G, because I got a call from Rachel when I was driving between Saskatchewan and Regina one day, and I pulled over to a gravel road, and I have a app for the technology on my phone, and I pulled up the patient and could view the patient through my phone. So it's that mobile. And so right now with the technology we have, with the phone and 3G, I can't necessarily listen to the patient, but I could see the patient. And at this point, I've developed such a trust in the local team that while viewing the patient and hearing what their assessment is, it's definitely easier to triage patients seeing them directly. So it's quite an accessible means of technology.
All right.
It's Elaine. Can I throw in one quick question, just for Tanya?
Sure.
Tanya, it's Elaine Orbine, and what a fantastic presentation. I can feel your passion as well as excitement. It's outstanding. Congratulations. Just a quick question, and I'm wondering if others are wondering about this too. From the provincial government perspective in Saskatchewan, I'm not sure if I missed this, and I apologize if I did. Is there direct support? Has there been a lot of negotiating, partnering, working with the government to really help support, promote, once, of course, your research findings are out there, and I have no doubt that you're going to prove tremendous benefit of this particular program, from cost efficiency to, most importantly, patient care.
So it's at this point, it's such a good question, Elaine, because that's what we're working on with ministry right now. Because at this point, the reason we only have one community is because it's an academic project. And it's our feasibility trial for pediatrics is the first trial that's really showing its benefit to for cost savings and to improving access in our province. And it started out as a University of Saskatchewan initiative and an academic initiative, and now our regions are starting to see that there is significant benefit for our patients and for our overall healthcare dollars. So I presented to the ministry just in June, and certainly everyone's awaiting for the final results of the trial, and then the plan would be to part of our transport budget, we would incorporate funding for having this technology in our most common catchment sites. And then other programs, adult programs, would benefit from that as well, and they could start incorporating care, and not necessarily all acute and critical care access or transport triaging, but they could be used for chronic clinics as well, which is one thing that I think would be incredible. In the next couple of weeks, we have I'm going to Rachel and I are going to try and organize a few of our pediatric cardiology patients and have to come to the clinic, and we're going to have our pediatric cardiologists come in and assess the technology to see if that they can do some of their follow-up remotely, because all cardio patients follow-up is in Saskatchewan. And so for these patients, even if it's a routine follow-up and they're doing not too bad, they travel 600 kilometers when they may not necessarily even need an echocardiogram. So Peds Cardio is very interested in looking at chronic clinics through this remote technology. So it's not, so that's the long answer to say that we're in the process of convincing ministry at this time through this feasibility.
You're absolutely right about the generalizability to so many different programs. So anyway, congratulations. It's just fantastic.
Thank you, Elaine.
So now Rachel is all set up in Pelican Arrows, so now we're going to hand the virtual podium over to Rachel to hear from her. We do have a growing list of questions that we will get to after we get a chance to hear from Rachel, though. So over to you, Rachel.
Hi, everyone. Thank you, Dr. Holt. That was wonderful. I'm Rachel Johnson. I'm a nurse practitioner practicing in Pelican Arrows, Saskatchewan. And as my bio had said, I'm actually originally from Toronto. So Toronto to Pelican Arrows is a little bit of a change. And one thing I really like to think about in terms of providing care to my patients here in Pelican is, what would I do if I was in Toronto? Would I hesitate to send them in? Would they be getting the same level of care available in Toronto or here? So today I just wanted to talk a little bit about Pelican Arrows, talk about Rosie the robot, or introduce you to her, and then discuss the impact on the patient, the family, the community, the nurses, touch on some of the challenges that we have faced, and look to some other applications. So I have no disclosures. Nobody pays me to do this, so if anybody wants to pay me to do this, I would be happy to list those on my conflict of interest. So this is beautiful Pelican Arrows. Opawakusakin is the Cree name, which means narrows of fear. I think my mom's relieved that we call it Pelican Arrows and not Narrows of Fear. It's a community within the Peter Ballantine Cree Nation, which is in the territory of Treaty 6. So you can see there's quite abject poverty here in Pelican Arrows, but that's in the face of one of the most beautiful parts of this country, I think. Having lived in South Africa in a rural community there, there's a lot of parallels in the living conditions. And it's really been quite humbling to see sort of some third world country living conditions here in Canada. Despite some of the challenges, and Pelican is known to be a pretty rough reserve, I would say overall it's a really vibrant community full of lots of spirit, lots of food. This picture on the left is the one that I had to do taste testing for or judging for a competition. So a bit about Pelican. Population is about 3,700 people, which is a very large community for our area. That number fluctuates, and I've never been given an exact number. It could be 34 or 4,000. It depends on who you ask. Median age is 18 years old, and that's a really relevant thing to consider, given that we're talking about pediatric transport. So half of our population, half of the 3,700 people are children, or pediatrics. I call it snowware. So we're down a 52-kilometer stretch of gravel road. Sandy Bay is our closest community. That's 70 kilometers away, but the Airstrip is 75 kilometers, and that's a really rough road. So that's our closest airstrip. The one just outside of Pelican Arrows is closed down, and I think there's some challenges with its off-reserve. Province isn't fixing it. I don't know all the details with that. But if we are transporting a patient, we have to send them either the 75 kilometers down to Sandy Bay Airstrip or to Flin Flon, which is 121 kilometers to the hospital. That's our closest hospital. And then the airport is an additional 20 kilometers further. Prince Albert is nearly 400 kilometers away, and Saskatchewan's over 500 kilometers away. So those are all pretty far distances, particularly given the condition of the roads. I'm going to just touch on this very briefly. You can see the red star is Pelican Arrows. The two stars, the green star, the two green stars is Sandy Bay and Deschambault Lake. And the relevance of those communities are that they are our ambulance service. We have one ambulance in Pelican Arrows, and it services all three communities. The blue stars are our hospitals that we access, so Flin Flon, Prince Albert, and Saskatoon. Angelique Canada Health Centre, so this is where all the magic happens. This is part of our team. So usually, often, hopefully, we have at least one physician. The main physician that we have is itinerant, and we usually have locums that sort of fill in the blanks, but we also do go periods without any physician support. It is technically a 9-nurse post, and our current complement includes 3 full-time nurse practitioners, myself being one, and a fluctuating 4.5 full-time equivalent of registered nurses. And our RNs do practice to a much broader scope of practice up here with transferred medical function. And then hopefully we get some casual nurses that bump up our complement to full 9 nurses, but we're perpetually short, as most other places I'm sure are. We also have other programs like home care, holistics, transportation coordinator, which I think is one of the most challenging jobs here, and administrative support, etc. So this is Rosie. I guess I'm not supposed to call her Rosie. We knew her as Rosie from the get-go, and the community has bonded with her being Rosie. But I found out a short time ago that another robot was named Rosie, and we're not supposed to call her that, but I think it's too late. So I'll start with talking about the impact on the patient as I see it. For me, the priority, the most fundamentally important thing for healthcare is that the patient gets the right care by the right provider at the right time and in the right place. And so Tanya really did a great job articulating this and really showing the benefits and the possibility of using the regionalization versus the critical care centers and tertiary centers. And we really can do a lot of the care right here in Pelican Arrows. We are a nursing station. We don't have any, we don't have capacity to admit patients. We work regular clinic hours, plus we do on-call on top of that. We don't have a day post-call to recover if you were up all night. If you're up all night, you're still back at the clinic for 8:30 in the morning. But we can do a huge amount of the care here. And it's about getting the care initiated at the right time. So our previous load and go, we generally don't like to talk much about scooping here because of the negative connotation the community experienced. But the load and go practice, we've definitely learned is not actually in the best interest of the patient. With using Rosie and with having access to Dr. Holt and now another pediatric intensivist, we can provide the high quality care to the patient at the point of care. So when they come in, and we're able to get them that specialized care right here at home. I'm not going to go much more into the earlier initiation of interventions because Dr. Holt did such a good job on that. Being able to stay in the community is huge for the patient and the family, which I'll touch on later. The more seamless transports and sending patients out stable, these roads sending out will often go to Flin-Flon, so that's 120 to 140 kilometers of bad roads. I've been in the back of the ambulance countless times with an unstable patient, and that is a really, really tense situation. We don't have any cell phone access outside of our community, so that is a long period of time where you are alone. So the safety factor for the patient is monumental. Improved continuity of care. So because I will be working with Dr. Holt on this, we're able to, and Dr. Holt's been able to see the whole process of stabilizing, transporting to the connecting site for the transport team that she's responsible to and has communicated with them the situation with the client, and then receiving the patient or the physician who does receive the patient ultimately. It's just a much more seamless, improved process. And then also, I would say improved follow-up, because especially follow-up we're able to do in the community. Impact on the family is, I think a big one is confidence in the care that the child receives. And they're becoming much more, it's not that the nurses were not good, it's just we now have that extra level of knowledge and skills and support, and the community, the family has definitely responds to that. We were worried at first that people would not be very receptive to using a robot because it was so depersonalized and whatnot. But patients now come in, children will come in, and I'll talk to the parents about wanting to use the robot, and they get so excited because they've heard it, they know somebody who's been on it. Another big factor is we have a very young population. Most people have multiple children, at 6, 8, or more. And if we're sending a child down, then we have to send a caregiver with them. That caregiver might have the 8 other children that they have to then sort out childcare and logistics for everyone else. So it is quite disruptive for the whole family unit. They become involved in the care here, which I find is very empowering for them. Impact on the community. So I alluded to the fact that we only have the one ambulance here in Pelican Arrows, and it services Sandy Bay and Deschambault Lake. Sandy Bay being the 70 kilometers further, and Deschambault Lake in the other direction, it's about 130 kilometers or so. And so if we're sending our ambulance out on an unnecessary transfer, that means that ambulance is out of the community for at least 4 hours. And that can be catastrophic if another critical situation arises. So a really important thing for me is using the resources we have, but using them appropriately. And being able to access specialist care online and decreasing some of the trips means that we're able to utilize our ambulance better. Again, pride for the community. Pelican Arrows often has a very negative reputation in the media. Usually it's only about various murders and assaults that come up. And this is something that has been giving a lot of positive attention to the community, and the community is proud of that. And again, the improved confidence and level of care provided at the clinic is important. Finally, the impact on the nurses. So mentorship, and this is the most important thing for me. My skills and my capacity as a nurse practitioner has, with pediatrics, has increased so much. We're actually starting to use the robot less, which is challenging for our study, because a lot of the cases that come in, we can actually manage now a lot better and very safely on our own before having to contact the specialist. So we went from almost overutilizing, a kid comes in and we have to call, to now being much more discerning about who we're contacting the specialist for. So I think that is becoming a bit more refined. So it's building our capacity to manage pediatric care here. Our skills, even things, IV starts, something I was atrocious at. I can tap a vein, I can bleed a rock, but I could never get an IV into a child, and now I can do it blindly with the support of Dr. Holt and really the practice of actually doing it. We're transferring stabilized kids, and so I mentioned being in the back of an ambulance with a really sick child where we actually don't have the lines in, we don't have a secured airway. They really weren't safe transfers, and we're doing, when we are transferring, we're transferring much more stabilized kids. The pediatric transport team has commented a few times for our much more critical patients that when they came in, and with Dr. Holt's help or Dr. Bradshaw's help, we have done such a great job in the care that by the time we got to meet the flight team, the pediatric transport team, the child was in such better condition, they weren't expecting it. It was like, no, that child was that sick. Also, the improved communication and trust and respect and relationship we have with the specialist, and I think it's mutual. That allows us to have sort of better and quicker interventions, but we're able to be part of that team that right at the point of care. So when the patient's coming in for follow-up at 2 in the morning, we've been part of that conversation. We know what's happening. We're not sending off a paragraph referral letter saying, please see this patient for blah, 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 and then a week later getting a note saying, thanks for the referral, they're better. We actually know what is happening with the care. We know what the treatment plan is, and we're able to support that and support the families. Some challenges. I think the biggest challenge, of course, is its change, and a lot of people are very change averse. I love change, but not everybody does. So we've had to really challenge some attitudes, and attitudes within the nurses, attitudes within some of the other providers as well, and just sort of honor that change is scary and work through together. Increased time and burden on nurses. I would debate whether this is a big challenge. It does take more time from the clinic perspective compared to the model of the load and go, where we're actually doing interventions here. Obviously, it does take more time. however, we're providing safer care. It's better for the patient. And we're actually doing fewer transfers, which means the nurses don't have to go on a 4-hour transfer. So I would debate that. I think an issue is the funding and the billing models for specialist remuneration. And that's something that is going to be addressed, but needs to be addressed, because that will be a huge obstacle in moving forward. Occasionally we have poor connection, which is, that's the nature of living in a remote community here. And I guess we're working on that. And Alphonse here on the right, who's one of our ambulance drivers, looks like he's having a challenge getting the, I think that's a beaver trap or something, set up for a king trapper competition. Finally, other applications. So a chronic kids clinic, which I have done with Dr. Holt on a few occasions. And we're finding that we've got much higher rates of attendance, so fewer no-shows, because we're able to do that within the community. Really exciting, we've been working with the physical therapists to do lower back pain and back injury assessments. And I'm the farthest thing from a physical therapist, but with her support, I've actually grown in my ability to respond to that. We've done a couple TB clinics. Dr. Holt was talking about interest from pediatric cardiology, and we'll be moving forward with that shortly. And we've had interest from an orthopedic surgeon from Winnipeg to see about doing follow-up. There really is so much potential. It's quite unlimited. And I will use this as my road forward. Like it's an obvious road forward, and it's beautiful. And don't mind the smudges that you see in the picture. Those are bug guts through my windshield. And for pediatric transfer, I'd like to just say thank you very much. And thank you, Dr. Holt, for really being so compassionate and so willing to work with us and make this successful. Okay, so that's it for me.
All right. Well, thank you, Rachel. And I did want to mention that the issues of communicating with folks in the remote areas. Your internet connection was a little slow, so you were always about one slide behind as you were talking. So a few people commented on that, but no, it's fine. It's all catching up now. We're now seeing the bugs on the window there, so it's all good. But a great presentation. Questions that have come in for both you and Dr. Holt. And this question came in during Dr. Holt's presentation, but maybe we'll start with you, Rachel, answering this. And you sort of touched on this in your slide about when you were talking about how the impact on the nurses and whether it's debatable on how this has affected the workload for the staff at the health centers. But Penny is asking, since the patient is staying in the remote setting longer, does that put stress on local resources and perhaps increasing costs for FNIB if it's a case that's covered by FNIB, or does the cost-saving assessment include that impact on the remote setting? That's the cost-saving assessment that Dr. Holt was talking about. So maybe we'll start with you as far as your impression of, does it, a little more into that, does it increase or decrease the workload on the local resources?
That's a really great question, and it is an important question. In terms of funding on FNIB behalf, I would say it probably doesn't have any impact on that, so it's much cheaper for them. The point is, I guess there's some children that do need to, that it does take more time with a nurse and a dedicated nurse if a child was coming in. And it's not an unmanageable addition. It's just, it's a different approach to the care. So I think the nurses and the model of care that we practice in needs to be adjusted a little bit to accommodate. The burden on the local resources would be, is mainly the nursing care. when I said debatable, with really unwell children, we're often having to call in extra support anyways and send nurses out on the transport. So whether we spend a couple extra hours at the clinic or a couple extra hours on the road, I don't know. For me, I think, and for most nurses, they would agree that access to care or the quality of care for the child is fundamental.
Do you have any thoughts on that as far as the cost impact and those sorts of numbers that you were putting together from the financial end? Did that take into consideration sort of any transfer of resources that would be required at the remote center, or?
For me?
No, for Tanya. Dr. Holt, are you still there?
Yes, so those are important evaluations that we have to look into more detail with. We're sort of course, we're trying to convince our regions that this is going to benefit the regional costs, and that will benefit, and then we go federally to the ministry to say overall the quality of care will be enhanced, and but those details of funding models will occur once ministries has decided to distribute this technology throughout the province. But those are important considerations, and it really actually comes down to there are going to be certain costs that are unexpected in the locally, but it will be weighing the risk-benefit of the philosophy of avoiding load and go, stabilization, prioritizing stabilization, and prioritizing a safe process for kids throughout from their presentation to if they end up in tertiary care. So, and it is a philosophy. It's an amazing thing that it's taken a lot of time to convince the appropriate people that when it comes to pediatric, particularly medical, critical care and acute care, loading and go is not the way to go for the patient ultimately. So we're always at the side of, well, if there's a few extra costs, maybe that's okay because it's better for the patient, but it's all a big balance. So, and I don't know the fine details of the costs locally, but that will all be a part of our assessment as far as expanding this program throughout the province.
I would just sort of add to that. So one of the expenses that has come up is that we've been trying to get better equipment so that we can actually do more. So for instance, IV pumps and an iStat machine and some things like that. So and more medications so that we can actually start more interventions sooner. I wouldn't say those are substantial costs. In terms of nursing, we use all the nurses we have, so we don't get overtime or things like that. We're not calling in extra staff for this, so it's not a financial increase in cost.
We did, Colleen was asking Dr. Holt when you were showing the data about how it's reducing transports, and just wondering how the transport team feels about doing fewer transports.
Well, so right now we have so many transports that I think the transport team sees it as they do want to be utilized that's appropriate. So if we can use our colleagues for our EMS colleagues when it's appropriate, we should be. Or if we can leave patients in their home communities and utilize our local communities for that care, we should be. It's all about providing the appropriate level of care to the patient closest to home. So, and the PEDS transport team, we've got such high volumes and just one team right now. They were very anxious for us to refine the way we were triaging, and ultimately they appreciate when there's a certain amount of, when the patient is stabilized prior to them assessing and picking up the patient. And the one patient that Rachel was referring to, where the transport team commented to her that their patients are stabilizing quite a bit before they get there, was a patient that we actually, with the team, changed disposition because through the remote technology, through a great local team, we stabilized the patient to thinking we might need critical care to actually thinking, no, we can regionalize this patient and they can be closer to home. So the transport team has been extremely positive about it. In actual fact, they've welcomed refining the way we're triaging.
We did have a question come in about when you, Dr. Holt, when you were talking about giving that story about how you stopped at the side of the road and used your cell phone with an app that allows you to see some of the information. Sarah was asking if there was personal health information issues with taking that information on a personal, like on a mobile device, or is the robot in general like approved according to provincial legislation or anything else? Was there a privacy impact assessment that needed to be done? Anything around that health information piece?
It's a really great question that I failed to comment on, and I should have. All the information that goes through the robotics is encrypted. The medical information is all encrypted, so it's safer than why wouldn't you just use your iPhone? But this the application is through the InTouch Health. That is the app that encrypts the medical data, so it is all secure and is a very, very important piece that makes this a secure means for information. Because I don't know it prior to this, and one of the reasons why we started looking into it is that I don't know how many transport nurses said, well, I'll just pull the patient up on my iPhone and we can FaceTime and you can see the patient. And my answer was always no, because that's not secure. We don't, it's not, the patient confidentiality is compromised there. So this is a really very secure, medically, all the medical data is encrypted, so it's secure from that point of view.
Great. We do have just, sorry, go ahead.
If anyone wants to see, I managed to get it working, so if anyone wanted to see at least a small couple of videos, I can run through them really quickly.
Well, I think we're just about out of time. We've got a couple other questions that I think we want to get in, and we only got, according to my clock, 1 minute left. So I don't think we can. Perhaps after we take these two questions, maybe we can just show a video at the end, and anyone who needs to leave can go, and maybe we can. Those who want to stay around and see them, we can show those videos.
Sounds great.
All right. This question came in from Colleen, and she was asking for future rollout of this. Is there any plans to put this anywhere else, and is it targeted at communities where there is just no physician access? Is that one of the requirements? Is it solely to be used as a support for nurse practitioners in those communities?
No, I think that you can use it anywhere, and it really depends on assessing the need in the community that you want to provide that technology to. For example, there isn't a pediatric intensive care in Regina, which is the other large city in Saskatchewan, and we often take calls from their pediatricians consulting us regarding whether the patient needs pediatric critical care, and we're trying to roll it out in Regina as a means to provide pediatric critical care consultation and triaging whether patients need to come to Saskatoon or not. We have another larger northern center, Isle of Cross, that has a robot there now that we're assessing their need because they have a big physician working group and assessing how they see their need, and it really has to come from the community to us. Maybe it's that they have admitted a patient overnight and they don't know if they should transfer because the patient's not getting better. Maybe we round with them in the morning to see if that's a possibility. So every community is going to have a different need, and that need is really has to be a collaboration, and you really have to discover that together. And so there's no limits to where it can be used and how it can be used. It's just how can you enhance patient care?
I would like to just, sorry, I'd like to add quickly that it's not just for nurse practitioners to use. It's for the registered nurses and the physician. This in no means replaces having a physician in the community, because we still do. But it's about getting the best person for the particular case. And pediatric intensivist in a lot of cases is that person. But it doesn't replace having a physician, nor is it specific for nurse practitioners.
That's a great point, Rachel. Thanks for mentioning that. And we've had other presentations going back a couple of years on telepsychiatry programs that provide access to psychiatrists and psychologists and other counselors and lots of other people that would all benefit from this. So totally, it's not just for the nurse practitioners for sure. So thank you for pointing that out. One last question, and then we'll maybe hand over to Tanya for a couple of videos. Colleen's asking about your transport program, Tanya. Is the transport team is housed within your ICU, correct?
Is that
correct? It
yes.
is. And so I think she's looking from the perspective of if their number of transports are reducing, what are their other responsibilities?
Oh, so they do intra-hospital transport. We're kind of like the roving team, so we support the pediatric acute care setting, and they're supernumerary. So they'll support if they're not out on transport, they support our pediatric emerge, or pediatric acute care with IV starts, with transports. When we do procedural sedation in the unit, they will help us with that. So we've got a vast array of responsibilities for them if they're not being used in the peripheral setting.
All right, so that's the end of our questions for now, and we are a couple minutes over, but we'll just take one or two videos from you, Tanya, just so we can give people a sense of what they should be seeing. And I will warn people, the videos will be a little bit jerky, just the way it plays across the webinar program. The audio will be fine, but the video will probably be not quite as smooth as it looks on the original version.
I'll run through these quite quickly because I already spoke, so I'll just run through the videos now. Okay, that's us going to a patient. This is us listening. That's the stethoscope diagnostic device that connects. I'm using a computer, but you can also use a laptop. This is Rachel and I discussing a patient the day after we saw this patient in severe distress. So I'll put on my headphones as well. Rachel, you put on your headphones too, and then we can listen together. Here. So we can listen together, and then if you have any questions around what you're hearing, we can talk about that as well. Okay. Okay. Thanks. Okay. So we'll do the anterior chest first. So we're still hearing some wheezing. Here's the capillary refill that I wanted to show you guys, how well you can see.
Feel that okay?
Okay.
Very good. So here. Yeah, there we go. Perfect. 1, 2, 3, 4, 5. Yeah.
My next word was, yeah, that's not good. Here's our little friend. That was her. How close?
Okay, other side, Rachel.
Here's our other friend that was very unwell.
Good.
You can actually hear him wheezing. It's so good, and you can see his head bombing. him more stable. Looking at him a little more closely.
Okay, he's looking a lot better. Got a good cough.
More alert. And then this is us discussing our triaging plans.
Quite a bit of troubles in the past with airways. He sounds much better, but I suspect he's going to need ongoing monitoring and probably some oxygen. So I think he's one that we should plan to send out. How do you guys feel? I can help arrange that. Now the question is whether or not Mom and Dad, I think PA knows him very well. I don't think he's so sick that he needs to go to Saskatchewan.
So that's us triaging. And just for a great way to end off, this is our little friend with.
Oh, she looks better, yeah.
She still easily has half of it.
Great. Okay. Hi, you look cute.
You really bond with the family. And then this is our final little guy, which we don't need to see that one. He just was doing much better. So that's just a little introduction to our videoing and how gives you a little bit more of an illustration of how it goes.
All right. Well, thank you for that. That really is helpful to see that. I think that was it's too bad we couldn't get those earlier. We did lose a few audience members that I'm sure had to go back to their actual day jobs, and so they would have missed it. But we'll make sure we have that in the recording for people to see afterwards. So you've gotten a little quiet for some reason, Dr. Holt, but we can.
Oh, am I quiet?
Yeah, you're just maybe perhaps a little bit further away from the microphone. I'm not sure, but that's. I think we do need to wrap it up now. So if you have any closing comments before we wrap this up.
No, I just I appreciate the opportunity to share this experience and just want to thank CAFC for all the important work they've been doing to really standardize the way we're mobilizing pediatric patients and caring for them and their creativity and all their support. So thank you, Doug, and thank you, Elaine, and thank you, everyone at CAFC. Thanks, Rachel, for joining us.
Yeah, it's certainly our pleasure. And Rachel, anything to close it off with?
I think I would just echo Dr. Holt there. It's really amazing to be able to share this. I'm very passionate about this because I really do see this as a really groundbreaking way forward of providing safe care and improving the care of all Canadians, which is one of our healthcare system we're so proud of that really emphasizes portability and accessibility, and we're able to do that. And so thank you for letting us share a little bit about that and sharing some neat things that we can do.
All right. Well, thank you for sharing. It really was a great presentation. I love the technology and all these crazy things that we can do now, so it's really awesome to see it in action. So thank you guys for coming. We do have to wrap it up now. We are quite a bit over time, but certainly well worth it. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great if you can watch live, as those questions that, as we saw today, really help enrich the discussion. But when you can't watch live, we do record these and make them available after the fact on the Knowledge Exchange Network. And we did have a number of requests for the slides, particularly yours, Dr. Holt, with the references. People were really interested in seeing some of those references. So if we could get those slides from you, we'll put those up there to share as well. Next week on September 23rd, we're once again going to hear from some of our colleagues in our rehabilitation community as we hear about the chronic pain assessment toolbox for children with disabilities. We're going to hear from two colleagues from Holland Bloorview Kids Rehabilitation Hospital, Christine Providenza and Ashley Townley. The toolbox aims to provide a standardized way to assess pain in children with disabilities, and those of you who might be part of CAFC's pain community of practice might have had a chance to hear a short presentation on this topic, but there was so much interest that we brought them back to the main CAFC Presents stage to the larger audience so that we can have a little bit more time to hear a bit more about that great program. And following that, we have the final part of our three-part series on patient safety that was sponsored by Mallinckrodt Pharmaceuticals. This is sure to be a great session to finish that one off with, as we hear from two real leaders in our healthcare sector, the former / retired CEO of the Canadian Patient Safety Institute, Hugh MacLeod, and the CEO of Kingston General Hospital, Leslie Thompson, are going to be joining us for that final session. Leslie has spoken frequently and openly about strategies at Kingston General to improve safety, but also to focus on patient experience. And the topic of that webinar is going to be a conversation about reimagining the roles of patient safety, quality, and patient experience. And as we work to improve quality and as we work to improve patient experience, are we making sure that safety is included? So that sort of holy trinity of patient care there. So it's going to be a really interesting conversation with some two great speakers. So lots of great stuff coming up. And then, and I also wanted to thank Prolacta Bioscience once again for their supporting our webinar program. So it's great to have them, and make sure you check out their session at the upcoming CAFC conference. So some great stuff coming up in the next few weeks. Thanks for joining us today, and we hope to see you back here next week. Bye, everyone.